I'm Dr. N.S. Mani, and this is the 7th in the series of ECG analysis of pediatric ECG, and this is the tutorial based on the ECG reading workshop. We stopped with the recognition of ischemia in the previous session. Many different electrocardiographic criteria have been proposed for identifying acute myocardial infarction in left bundle branch block, but none have yet been proved sufficiently sensitive to be useful in acute setting. However, some features are specific indicators of acute ischemia. ST segment elevation in association with a positive QRS complex, or ST segment depression in lead V1, V2 or V3, which have predominantly negative QRS complexes, and is not expected in an uncomplicated left bundle branch block, and is termed inappropriate concordance. Inappropriate concordance strongly indicates acute ischemia. Extreme ST segment elevation equal to or more than 5 mm in lead V1 and V2 also suggests acute ischemia. If doubt persists, serial ECG may show evolving changes. Now we shall start with some exercise for just trying to recollect how far we have learned. So read the ECG and come to a conclusion. I will show the ECG just for a few seconds, less than 10 seconds. Now there is sinus tachycardia. You just count the number of boxes in between the RR and you'll find that it is faster. So you count the number of RR small boxes, and 1500 divided by the number of small boxes will give the how much is the rate. So if it is 10 boxes, 1500 divided by 10 will be 150. If it is 20 boxes, it is 75. If it is 150, it is 100. Sorry, if it is 15, if the number of boxes is 15, it is 100. Now there is a exercise number 2 showing an ECG. Read the ECG and find out what is the abnormality. Just a few seconds, because in the exams, especially in the objective structured clinical examination, hardly 30 seconds are given, because you have to read the clinical details also. You can always replay the video. That is a U wave in lead V1 to V3 in patient with hypokalemia. In one of the previous tutorials in the ECG, I have shown you the components of the ECG waves, that is PQRS, TU, and that we have mentioned about IU waves. Now what is this showing in the ECG? Question number 3. It's an easy one to read. It's only simple severe sinus bradycardia. The pathological causes of sinus bradycardia are acute myocardial infarction. Drugs like beta blocker, digoxin, amiodarone, obstructive jaundice, raised ICT, sick sinus syndrome, hypothermia, and hypothyroidism are other causes of sinus bradycardia. Now what is this shown in question number 4? That is the sinoatrial block. Note the pause is twice the PP interval. Sinoatrial block is characterized by a transient failure of impulse conduction to the atrial myocardium, resulting in intermittent pause between P waves, and the pauses are the length of 2 or more PP intervals. Now that is question number 5. What is the diagnosis? So that is the sinus arrest with a pause of 4.4 seconds before generation and conduction of a junctional escape beat. Sinus arrest occurs when there is a transient cessation of impulse formation at the sinoatrial node. It manifests as a prolonged pause without P wave activity, and the pause is unrelated to the length of the PP cycle. What is this question number 6? That is the first degree AV block, that is first degree AV block with a delay in conduction of the atrial impulse to the ventricle, usually at the level of the atrioventricular node. This results in prolongation of the PR interval to more than 0.2 seconds. A QRS complex follows each P wave and the PR interval remains constant in this case. What is this? Question number 7. That is Mobitz type 1 block with the Winkie-Back phenomenon. Mobitz type 1 block Winkie-Back phenomenon is usually at the level of the AV node, producing intermittent failure of transmission of the atrial impulse to the ventricle. Initial PR interval is normal but progressively lengthens with each successive beat until eventually AV transmission is blocked completely and the P wave is not followed by QRS complex. The PR interval then returns to normal and the cycle repeats. Question number 8. What is this? That was Mobitz type 2 block, a complication of an inferior myocardial infarction. The PR interval is identical before and after the P wave, that is not conducted. Mobitz type 2 block is less common but is more likely to produce symptoms. There is intermittent failure of conduction of P waves. The PR interval is constant, though it may be normal or prolonged. The block is often at the level of the bundle branches and is therefore associated with wide QRS complex. 2:1 AV block is difficult to classify but is usually a Winkie-Back variant. High degree AV block which occurs when a QRS complex is seen only after every 3, 4 or more waves. It may progress to complete third degree AV block. What is this 9? You are helped by arrow marks. That does the third degree heart block. There is a complete failure of conduction between the atrial and ventricle with the complete independence of the atrial and ventricular contractions. The P waves bear no relation to QRS and usually proceed at a faster rate. And third degree heart block, a pacemaker in the bundle of His produces an arrow QRS complex and arrows show P wave. And that is the question number 10. There is a right bundle branch block showing the wave of depolarization spreading to the right ventricle through the non-specialized conducting tissue in the right panel on your right side. We already dealt with in one of the previous sessions about how to diagnose RBB. So I hope that you enjoyed this session with questions. More similar questions and exercise also will follow in this channel, youtube.com/acpgmed. I'm Dr. Nasmane. Goodbye.